Good afternoon. Okay, today we're going to talk about the role of cardiac CT for comprehensive coronary artery disease assessment and management. And the focus is what is beyond the diagnosis of anatomic stenosis that CT has been always attributed to have a capacity of providing the anatomical information. So how things has changed throughout the time. So you can see this 2012 American guideline for diagnosis and management of patient with stable ischemic heart disease, which is kind of fairly similar to when I was a fellow back in early 2000. Patients show up with a suspected CAD with some symptom, and our goal is to find out if the symptoms are related to ischemia. We do a stress test, and if it's normal or low risk, we treat them medically and basically what we call guideline-directed medical therapy, based mostly on clinical risk factor. And you can see there when the role of cardiac CT back then has been limited to patients who cannot have a stress test, or if they are unable to exercise and have intermediate or high likelihood of ischemic heart disease, that would be indicated CTA, as well as together with pharmacological stress CMR. But interesting thing is the focus of the CTA in this 2012 diagnosis and management guideline is the extent of severity of angiographic CAD as the most important prognostic factor and essential for management. So the focus entirely is we try to use the CTA to determine if they have basically severe three vessel disease or significant stenosis to guide revascularization. There's no mention of guiding using CTA to guide medical therapy. This is in 2012, and it was an update in 2014. Essentially, nothing was added in terms of a role of the CTA. And you can see 5 years later, in 2019, European Society changed their guideline, essentially putting CTA at the same level of essentially the stress imaging test for management of patient with suspected CAD. And so what changed between 2014 to 2019 is the CTA has gone through a tremendous transformation in terms of data and research that allow us to place it in the front of the initial management strategy for patients with suspected CAD. So in the past, CTA research and clinical application essentially mostly focus on luminal stenosis assessment and a little bit of plaque imaging. And you know now, function analysis there's a lot of data, CTFFR, myocardial perfusion, but I think the future will be mostly in the plaque imaging. Obviously, luminal stenosis and function analysis will be still important. So let's go through some of the data. Okay, what's the diagnostic accuracy? This is mostly for our fellows. There's 3 major prospective multi-center study examining CTA, diagnostic CTA compared to invasive angiogram. And all the data was used mostly 64 detector CT. So you can see because of the newer generation CTA, one could think the diagnostic accuracy could be a little bit better. So basically, what I want you to focus here is the sensitivity is clearly very high. Negative predictive value is also very high, and with this exception of Core 64 study, and the main reason is probably Core 64 include patients with known history of coronary disease. So if we focus on using CTA in patients without history of coronary disease, you can see CTA is very good in excluding presence of disease. But I think to dig a little bit further, there's a consortium of European, mainly looking at prospectively, all the prospectively performed CTA study comparing diagnostic accuracy. I'm sorry, compared to invasive coronary angiogram. You can see they look at 65 study over 5,000 patients. So as you could imagine, the diagnostic accuracy vary depending on the pretest likelihood of coronary disease. Lower the pretest likelihood, obviously the higher negative predictive value. If you include non-diagnostic study, it's 97.8%, and excluding non-diagnostic study, essentially still it's a little bit higher, and higher the pretest likelihood, the lower your negative predictive value, and higher your positive predictive value. So this is not totally surprising. So still, I think CTA is still the best in excluding disease in patients with lowish to intermediate pretest likelihood of disease, up to about 50%. And mostly, you want to have a good diagnostic study, which in most of the cases with the newer generation CT scanner and proper patient preparation, I think most of the study fall into diagnostic diagnostic image quality. And also it's important to notice that the diagnostic accuracy is a little bit lower for women, especially the sensitivity. And it's not surprising here. Older the patient, lower the specificity. And so this is important for us when we look at the patient that you test. Okay, so I think we all agree that nowadays the clinical relevant question when you have a patient with suspected CAD is number one, you want to know if the patient has coronary disease. And after that, you want to see how bad it is, and then you want to kind of answer, okay, what do we do with the patient? I think is ideally you want to have this type of coronary CTA, completely normal, no disease, and this has excellent prognosis in terms of both cardiac prognosis and non-cardiac prognosis. This patient have a little bit of disease, so mostly medical therapy. We could argue what type of medical therapy and how aggressive. And then you have patient with this more severe disease, obviously optimal medical therapy or guideline directed, plus minus revascularization depending on patient's presentation and symptom. The problem with assessment of coronary disease, coronary artery stenosis, obviously is we do not know what the functional significance, meaning if you see a stenosis, you don't know how is this hemodynamically significant or cause ischemia or not. And this has been shown in multiple studies, including the days that we do just invasive angiogram. So very, very low specificity, low positive predictive value. Having said that, all those data focus on coronary CTA only. As you can see, if you have this type of stenosis, a critical stenosis, most likely probably subtotal occlusion, total occlusion, those are very specific for hemodynamic significance. You really don't need to do any functional testing if you see a lesion like this. And if you add some more information outside luminal information, meaning go beyond the coronary and look at the left ventricle, kind of not so different from when you do a gated study, gated SPECT study. You don't only look at the perfusion, you also look at the EF, look at the EKG. Same thing with the stress echo. Look at, in addition to wall motion, you look at chamber size changes, ECG changes. If you add information like this, the specificity could be even higher, such as this non-coronary finding in very specific for prior coronary events like heterotropic calcification, hypoperfusion, the apex, fat infiltrations, pseudoaneurysm, and you have wall motion abnormality, or you have evidence of a wall motion abnormality, presence of clot, or a patient with here with a VSD. But when you have lesion like this without left ventricular finding, then you are stuck with, okay, if the patient's symptom corresponds to ischemia caused by this, what we call moderate lesion, or patient with severe atherosclerosis, but no clear critical stenosis. So there's a couple of ways of assessing functional significance of coronary lesion seen by coronary CTA. Number one is doing a myocardial perfusion, and we can do CT dynamic. We can do relative perfusion, such as what we see in SPEC, or we can do dynamic myocardial perfusion, which allows you to calculate the flow. So essentially, you have diastole and systole, and most of the imaging what we get is stated doing systole, and this is a parametric map who allows you to semi-quantify, depending on attenuation factor, amount of myocardial contrast, and you can see this not so different from, for instance, myocardial contrast echo or CMR, dynamic CMR. So obviously this require additional CT, meaning that you need resting and stress. This is just an example of what it looks like, for instance, in a study, dynamic perfusion study. We don't do this routinely, mainly because you need additional CTA scan, one resting and one vasodilator. So other vendors, for instance, Canon or GE has whole heart imaging. So essentially they can perform this dynamic position in one cardiac cycle, in a single heart in multiple cardiac cycle, allowing similar evaluation, one injection, one acquisition, because you can start with resting, but obviously there's some radiation is an issue. That diagnostic performance has been shown to be very, very good, comparing to invasive FFR with quantitative myocardial flow, blood flow, with the area under curve around 0.95. So essentially it's a well-validated technique, and is not being used widely just because of things I already mentioned. You require a high-end scanner and require additional radiation. This different approach, combining non-invasive CTA, meaning you use the coronary lesion and you add the myocardial perfusion by CT, and then compared to invasive angiogram plus SPEC. This is one of the study coming out of Johns Hopkins, core 320, and basically shows that if you add perfusion information on top of coronary CTA stenosis information, is much more accurate to predict significance of vessel functional significance. And there's also been study comparing CT perfusion, compared to CMR. And again, I can just obviously just focus on this data that the correlation is very good. So combination of CTA plus myocardial perfusion with CT is well established. But again, to circumvent the need for performing 2 studies with additional contrast and radiation added, CTFFR, as we all very known, has been around for quite some time right now. You can essentially derive a detailed functional significance of a coronary lesion purely an anatomical data set, meaning you just do your regular coronary CTA without any additional vasodilator stress, no change of CTA protocol, no additional images, and using computational fluid dynamic modeling, you can derive this functional significance of certain lesion. And obviously, that's not the only way of performing it. And as a matter of fact, you can also use machine learning. Even the HeartFlow platform I believe doesn't use CFD, purely CFD anymore. They also incorporate some machine learning protocol into it. And obviously, there's quite a few studies showing that there's a reasonable correlation between the CTFFR with invasive FFR. But the correlation is not far from ideal. You can see out of this study, as most of the diagnostic testing study, initial study that's been described has been a little bit always better compared to subsequent study, multicenter study. So you could see, we're talking about accuracy, it's around 80%, which if you think about is not much better than functional study using non-invasive strictly functional-based studies such as a myocardial perfusion, either with PET, SPECT, or MRI. So this is some of the examples when things work, meaning that some patient could have roughly 70% stenosis. You could have one with quote unquote normal CTFFR, which I don't like to call normal, but rather than likely of non-hemodynamic significance of 0.86, or the other one of 0.7. And in this case, correlate reasonably very well in the invasive FFR based on invasive angiogram. So, so this is just one example how we use this. This is a patient with a calcium score over 1,000. And we discussed that with the referring doctor. He insists that we go ahead and perform the CTA. I think that studies are reasonably diagnostic. You can see we have severe atherosclerosis, probably no significant left main disease, and probably no significant proximal vessel except for LAD here. Our CTFFR was performed, and you can see there's some lesion. The LAD lesion appears to be non-significant, and one of the circ lesion right here appears to be hemodynamic significance. So how is this CTFFR-based approach work? So the platform study essentially look at for patient who is actually a very clinically pragmatic study, basically. So it doesn't drive a protocol. Essentially, these are people who has planned, has been scheduled to go through the cath lab to have invasive angiogram. You can see, obviously, 100% of the patient who was supposed to go went for angiogram. The other cohort, they added CTA, FFR. As you can see, only 40% of the patient went to cath lab, and you can see that as only 12% of the patient who went to the cath lab based on CTFFR result have non-significant obstructive disease. So essentially, meaning that the diagnostic yield of the invasive angiogram is much higher than usual care. I mean, because only 27% of the patient has significant, more than 50% lesion. So 83% of the patient avoided an unnecessary invasive testing. And the 1 year from the enrollment, I mean, the cardiovascular death and MI, obviously there's no significant difference in terms of the outcome at 1 year. And when they look at the difference between the CTFFR more than 0.8 and less than 0.8, you can see there was a significant difference in a subsequent larger study. So it appears to be, so I think it's relatively well accepted that CTFFR, if you add CTFFR in a relatively good image quality, diagnostic image quality study, you can definitely avoid sending the patient to the cath lab, or other way of looking at it, you increase the diagnostic yield of your invasive procedure. It appears to be safe, and in a large group of patients, non-randomized, obviously, a CTFFR cutoff of 0.8 was capable of predicting patients' outcome. Already, again, this has been replicated in quite a few images, quite a few large studies in thousands of patients. Average increased cath lab efficiency of 70%, and this probably one of the best well-done study in Denmark, because over there, I mean, they have a national policy in several institutions where they do CTFFCT in every single patient. And you can see, excuse me, the outcome with a patient who had intermediate lesions or intermediate stenosis by CTA and have a normal or non-hemodynamically significant CTFFR. The outcome is very similar to patient who has no or minimal disease. And and those who have CTFFR less than 0.8 or ischemic lesion, quote unquote, by CTFFR, and when they went to invasive angiogram, appears to have better outcomes than patients who did not undergo invasive angiogram. This is a little bit more controversial, I think, because here they're claiming that if you use CTFFR, you send the patient to the cath lab, you improve outcome, than deferring it. So the UK got NICE, or National Institute of Healthcare Exchange. So one of the most first and most supportive of using coronary CTA as the first line of diagnostic testing for patients with suspected CAD. And they essentially went out and endorsed, if you have a borderline or moderate lesion, you should go ahead and do the CTFFR. And they even, as the UK, they do a lot of cost-effective analysis showing that you can save money. Obviously, this is not, CTFFR is not the same as invasive FFR. You have a relatively considerable rejection rate. I think in our experience in most of the study, we are talking about between 10 to 20% rejection rate, meaning the image quality is not good enough due to motion, calcification, or low contrast. And you have to, this is very important. I mean, the model of CTFFR is based on patient receiving nitrate. So when we do a TAVR study, we don't give a nitrate, and I don't think we should send the patient to CTFFR in fact, we don't, but a certain center they do. We have to make sure when we interpret the study to see the patient did not receive nitrate, the number you get is hasn't been studied. So, and again, severe calcification is problematic. Heart flow has some studies showing that it doesn't affect too much that the CTFFR, the correlation with invasive FFR, but I would like to see more study performed. And important thing is it hasn't been studied in patients with stent or prior CABG. And obviously the cost is always an issue because it's cost associated with sending the patient for CTFFR is not trivial. So what other evidence out there support the CTFCT for use of as a first test a patient for evaluation of patient with suspect CAD? You probably heard about the Scotthart Study, and this is a 5 years follow-up again and confirming this is one of the first studies that allows CT to show improved outcome compared to standard care. Bear in mind the standard care in this case mostly a patient who underwent a physical exam plus treadmill exercise. Excuse me. So you can see that use CTFCT as a first line diagnostic test is associated with a lower death and lower rate of non-fatal myocardial infarction. So this is I just mentioned, and some study had come out extending quote-unquote warranty period of normal CTA up to 8 years. As you can see, patient with no coronary disease, 0 normal, whatever you want to call it, compared to patient with non-obstructive disease and patient with obstructive disease, as you can see, up to 10 years follow-up. Essentially, this is as good as anybody who walk on the street without any symptom. And this is very important as well with the newer scanner, the radiation dosage reduction, at least in this protective registry of the last 10 years has dropped by 80%. And I would think this number is definitely a real world. And if not, I think if you're a first line, top of the line scanner and pay attention to heart rate, you can achieve that radiation dosage, even I would say half of the radiation dosage possible. So I mentioned earlier, but I think the most important information right now, I think that we can derive from coronary CTA besides degree of stenosis or functional significance. I think the most important thing that we're gonna get is atherosclerosis burden. I say that because after the ischemia trial, I don't want to go into debate about anatomy versus physiology, but I'm kind of putting down that, what do we want to achieve? What are we going to do when you have a mid-LAD, mid-RCA lesion, which, you could have 70, 80% lesion. So does it matter? Is ischemic and myocardial perfusion, SPECT, PET, or you do the CTFFR is 0.7? Because we know if revascularize this patient probably do not improve outcome. So what's left to do? And so I think the most important information, there's more and more data coming, and that atherosclerosis burden is probably more important and more helpful and help us manage the disease. In this case, instead of you saying coronary CTA, I would use coronary CT because calcium score based on non-contrast coronary CT is very useful. Just to give you an example, in this review article we wrote for JACC Imaging almost 8 years ago, this is a patient with coronary kidney disease and dialysis. As you can see, this is a 42-year-old guy with multiple risk factors, been dialysis for 3 years, normal stress test, no calcium, 4 years follow-up, guy is completely doing very well. And this is another guy about the same age. He's been dialysis, very similar risk factor profile, except he's more obese. And been dialysis for 19 months. Again, I would argue that this is pretty good perfusion imaging. And he has a calcium score of over 1,000 in all 3 coronary arteries. And he had a non-state elevation MI 3 years later. And this is one of the things that one of the study, multi-center study that I participated with some investigator from Italy, looking at 54 study over 35,000 patients with angina and non-obstructive coronary disease and CTA or invasive angiogram, follow up to 5 years. You can see this patient overall prognosis is not too bad, less than 1% per year. And he was talking about middle-aged person. And what's interesting here, you can see if you have completely normal coronary arteries, your event rate is about 0.5%. So this is as low as you get. If you have coronary atherosclerosis, and obviously the study we didn't quantify the degree of, but less than 50% stenosis, the event rate is 1.3%. And this is actually very interesting. In those studies where myocardial ischemia was present, there's not much difference between those who have myocardial ischemia as prerequisite to get an anatomic evaluation. So this is non-significant difference, meaning that if you have myocardial ischemia as entry criteria to be sent for anatomical evaluation versus myocardial ischemia is not required, there's no significance. But fortunately, we do have information in terms of what type of stress test was required. No surprise here, if you have in this case, most of the study who use treadmill ECG was essentially useless, meaning that if you have if you have an anatomical evaluation based on stress ECG information, the event rate doesn't matter if you have ischemia and treadmill or no ischemia and treadmill. But if you have if you use imaging study, there was a difference in terms of event rate, meaning that if you have a normal stress test, stress imaging, the event rate is higher. So, and basically this is, we did this study already back in 2009, showing that, adding calcium score to functional imaging increase. Okay, so I just want to, in the last 10 minutes or so, I want to show you a couple of new study to probably would widen the use of coronary CTA. I think I sent this to the fellow who presented a very interesting case, a patient from Professor Ron last week. What are the outcomes using different imaging guided strategy versus routinely sending the patient with non-state elevation MI to the cath lab? As you can see that it's not a big study because obviously most of the people who had come with positive troponin, some of them going to have contraindication to the CMR or CTA, or some of them because the clinical presentation need to go to cath lab urgently. Some of them essentially is clear-cut type 2 MI or very old patients. So essentially out of 770 patients, 200 patients was entered for a study. So this is very important, that you need to read this carefully instead of, going back to taking care of the patient this afternoon and you start adopting this strategy. So 200 patients, and so 70 patients went assigned to routine care, meaning they scheduled to go to invasive angiogram first, and 1/3 of patients went to CMR and 1/3 of patients went to CTA. So there's some difference in changes in terms of management, but overall, the compliance rate was fairly similar, and the follow-up outcome up to 1 year, I think, was relatively reasonable. You can see this is quite fairly representative of patients taken care of. And it's not surprising because the non-intervention MI, women and men are very equally representative. The interesting thing is the main difference here, there are more men will undergo CTA first. This is important. It's a European study, so size of the patient are not terribly big. They have significant risk factor, and the GRACE score is overall not the highest risk, meaning this is a patient that who have positive troponin. You think they have non-intervention MI, but they don't have a very clearly ischemic presentation. So this is very important to bear in mind. You can see, so CTA jump out to the one that probably is most effective in avoiding the patient to go to the cath lab. So patient, essentially 1/3 of the patient never went to cath lab. So if you went to CMR first, almost everybody will end up going to the cath lab. In 87, and certain number of patients also, instead of going to the invasive angiogram, having coronary CTA. So if you do CMR approach, most of the patients will end up having some anatomical assessment. You can see the safety between routine care and CMR and CTA first approach for major adverse event up to 1 year. So essentially, either strategy fairly safe. The difference here is CTA at first approach avoid more invasive angiogram. And I have to say that out of those patients who went to CTA, about a good percentage of patients end up having CMR, especially in patients who has no significant disease on CTA, which is essentially not surprising. And I think the yield of those patients who undergo CMR after normal or non-significant stenosis and CTA is very high, meaning I think it's one of those 6 or 7 patients who went to CMR end up having a new diagnosis. So it's reasonable approach after a normal or non-significant coronary CTA. CMR will be a good test to use. And I think this is pushing the boundary, meaning that this, again, a European study, essentially patient with non-intervention MI, 2,000 patients, they have separated into very early group, meaning that very early utilization of CTA in the first 12 hours, essentially. They come to the hospital, has positive troponin. They went to CTA. If they need invasive angiogram, everything was done within 12 hours. And then they compare the standard of care, meaning patient would show up with non-elevation MI, if the clinic stable. Obviously, they wait 48 hours, either get a CTA. And patients who are ill, obviously, is not enrolled in this patient, meaning they have to go to cath lab early, they go to cath lab. So essentially, this is a study in relatively stable, clinically stable patient with non-intervention MI. They compare a very early CTA approach versus kind of standard later CTA approach in about 2,000 patients. There's some changes, obviously, as you can imagine, during this period, some patients get ill, got excluded. So they end up having about half of the patient for analysis. Again, this is purely diagnostic accuracy study, meaning that you compare basically look at the feasibility to do an early coronary CTA in patients with non-elevation MI, which obviously we always frown when we're reading in the CT lab, and someone ordered a CTA with a positive troponin. Well, this is the type of data that you can provide right now. Is the negative predictive value is about 90%. So the diagnostic accuracy doesn't change too much if this approach was adopted early, meaning the first 12 hours, or after 48 hours. It's important to know that this study was done about 5 years ago, and most of the study was done with 64 slice CTA. I think only 20% of the study was used top of the line scanner. So I'm pretty sure this number would look a little bit better. But again, so I think I think although it's not indicated by current guideline, I think it makes sense in a patient who had positive troponin, you think a non-elevation MI, but the pretest likelihood not very high for coronary disease, such as the patient, I think that George presented, and this young woman who had ST elevation, had positive troponin, instead of sending patient to the cath lab for invasive angiogram, which I think the risk is a little bit higher in MI setting than stable coronary disease setting, I think it's reasonable to use this patient without significant clinical risk factor or ECG, and you suspect that the MI is not caused by ischemic event. I think this is the most important slide I want to present. If you don't remember anything I talk about, is this is one of the postulated mechanism for which use of CTA compared to standard of care. Important to mention, compare mostly to treadmill ECG in management of patients who show up with symptom and you suspect coronary disease. CTA approach has a better outcome. And one of the postulated mechanism is obviously by knowing the patient have atherosclerosis or not, one change the clinical management. As you can see, it was a significant increase in use of statin and aspirin, not by a significant amount. So this is not changes of 50 to 80%. We're talking about small changes. Having said that, you can see in CTA group versus standard of care group, after you change the timing, this is a time where this treatment was changed, the curve starts separating until about a couple of years, and which remain kind of stable. So I think this is kind of makes sense, meaning that when you see a patient with suspected coronary disease, knowing the patient have ischemia or not, like we do when I was a fellow, or even up to about 10 years ago with stress test, is no longer enough. I think the American guidelines still place emphasis in looking at extension, how extensive, how severe the coronary disease to decide revascularization. And now with the ischemia trial published, I think the focus shouldn't be focusing on extent of coronary stenosis, but rather than extent and severity, maybe even type of coronary atherosclerosis, and help us determine what kind of therapy or how aggressive. Because in the study that we published in JACC, comparing SPEC and calcium score, and that I showed you earlier, in those patients with 1,000 calcium score up to 12 years, not everybody will have a coronary event. Even those patients who had a normal stress test and coronary calcium score 1,000, only half of them will have event. You would think those are extremely high patients and they should have event. Everybody should have some type of event after 10 years. But only about 50% of those patients has event. So you could argue that those patients with 1,000 calcium score those who have event probably are those who also have a lot of non-calcific plaque, compared to those who didn't have event, probably have, severe stable calcific lesion and not much unstable plaque. But that's area that will require more research. Okay, so in conclusion, coronary CT, I put a coronary CT here, not coronary CTA, because calcium score is an important part of the coronary evaluation, and it's accurate for assessment of stenosis for CTA, excellent predictor of future cardiac event, this both for calcium score and degree of overall coronary stenosis. It provides functional significance. Obviously, this can be achieved only by CTA. And the important thing is what the patient really cares is, if you help us to help them in guiding the therapy and hopefully improve their outcome. Okay, that's all I have, and I'm happy to take any question.
Hi, Suman. This is Maz. Can you hear me?
Yes, I do.
Okay, so very good overview over the role of CT and how it advanced over years. And I have a comment and a question.
Sure.
First one is regarding the use of CT in non-STMI. I think I agree with you in terms of it's pushing it over the limit, especially that many of these patients, the images obviously will show a lot of diffuse disease and non-obstructive disease, and these are usually difficult to interpret, and the positive predictive value or the accuracy of the interpretation may not be as high. I would probably say that I would use it in patients with troponin positive if I don't believe that the patient has obstructive coronary disease. So in patients with high likelihood of myocarditis, pericarditis, and you want an anatomical study to assess coronary disease. Were these the patients who were included here, or these were like typical acute coronary syndrome patients with positive EKG and regional wall motion abnormalities? So these are patients that they thought that they were having coronary disease and they really wanted the CT to look at the evaluation of these patients, because if it was true coronary disease, these patients are going to go to the cath lab anyway for therapeutic options. So I don't see adding a test that will utilize contrast and radiation in the way as a mean to decrease the number of cardiac catheterization. You still need cardiac catheterization in these patients for therapeutic intervention if needed in acute coronary syndrome, which, by the way, these patients were excluded from the ischemia trial. So I think still intervention have a role in these patients.
Yeah. So this study, again, as it's a prospective study, this is very important. It was done in Europe. So they excluded essentially patients who, quote unquote, they have indication for early invasive studies. Essentially, patient with clinically indicated, clinician decide if the patient need to go to cath lab within the first 12 hours, they are excluded. I would imagine this was a patient with, clear-cut ST changes, dynamic ST changes, large troponin leaks, and as you mentioned, with wall motion abnormality, but in those patients who you kind of not sure, or at least clinically stable enough, I wouldn't say low risk, because you can see here, 130 patients are diabetic, so about 15%, a lot of smokers in Europe, a lot of patients with hypertension, quite a few COPD, so that go with the smoking. Even patients with history of cardiovascular disease, 25%, 15% have prior MI. They include patients with PCI, and half of patients with grade score over 140. So not exactly what we call lowest. I would say probably low to intermediate risk, and even some patient with new ECG changes was included. So this is a fairly, I would say they didn't cherry pick low-risk patient. And to answer your question, I agree 100% with you. You can see, the negative CTA is only seen in 26%. So, they call positive in 69%. So I guess they were very aggressive in calling normal or abnormal. They didn't leave out too much what they call diagnostic. And I think this is important, even with even with 64 slide scanner, they were able to achieve this diagnostic confidence, I would say. I think, if you call normal, it's probably all normal. So this group of patients probably quite represented what we see. And I agree with you. I mean, we can argue, what would be a reasonable use of CTA, non-invasive version MI. I would agree with you that if you do a planning scan, you see a lot of calcium, you probably want to stop there and go to different route, either invasive or functional testing. But if you don't see that much calcium, and I think you can increase the yield of negative CTA at a much higher rate. And I think it's important to avoid, testing in this patient which invasive angiogram carry a higher risk of complication. Yeah. Any other question? Okay. Yeah, thank you very much.